Hello friends, this is Dr. Ganga, your nephrology educator from PrepLadder. Today let us learn about PSGN and other infection-related glomerulonephritis. Now this topic will be dealt under the following headings. First we are going to learn about PSGN, then IgA dominant IRGN, endocarditis associated IRGN, shunt nephritis, other infections, other bacterial infections. Then we are going to see the KDIGO guidelines. Then we are going to see the virus causing glomerulonephritis, especially hepatitis B and hepatitis C, and malaria and other parasites, and further quick revision. Okay. Now, what is the etiology and pathogenesis of post-streptococcal glomerulonephritis? Okay. So this post-streptococcal glomerulonephritis is basically immune complex formation. So if there is an antigen, that is because of the streptococcus, right, which is Streptococcus bacteria, and an antibody goes and binds it. So this becomes the immune complex. So this immune complex can go and bind in the endothelium. We know that it is made of three layers, right? Filtration barrier. One is endothelium, which is nothing but the glomerular capillary. Then there is GBM. Then there is epithelium, which is nothing but the podocyte. So the first mechanism is passive entrapment. That is, this antigen antibody complex goes and binds and sits passively on the endothelium. The second is in situ complex formation. That is, what happens is this passively bound antigen dissociates from this antibody, moves to the subepithelial space, okay, and there they form the antigen antibody complex, because this antibody also will move. So this becomes in situ immune complex formation. Third is molecular mimicry. That is, antibody in the blood recognizes some antigen in the GBM and goes and binds to it and creates the immune response. So these are the three mechanisms by which immune response happens in post-streptococcal glomerulonephritis. Now, which are these antigens? There are two important antigens. One is nephritis associated plasminogen receptor. Okay, so it is associated with glomerulonephritis, that is NA. And plasmin receptor is important. It's a receptor which the antigen binds to, activates complements. Okay, so that is the first. Second is streptococcal pyrogenic exotoxin B. So this is the second antibody. Okay. Now, continuing the etiopathogenesis. So what happens once these antigens are present? They activate the plasmin. Okay. Once they activate plasmin, they activate complements, which is alternative pathway. Now coming to the streptococcal pyrogenic exotoxin B. If you see this streptococcal pyrogenic exotoxin will generally come to the subendothelial space, but the cationic antigen is going to dissociate and transition from the subendothelial space and go into the subepithelial space. And this is the only antigen that you see in the subepithelial space. Once it reaches the subepithelial space, it is going to elicit an immune response and lead to subepithelial hump. Okay, so you can find the same things here. Now, these patients not only produces antibody that is specific to their condition, but there's a generalized autoimmune response, because of which there is generation of other antibodies. Like these patients can be ANA positive, ANCA positive, rheumatoid factor positive, anti-C1q positivity, and also autoimmune hemolytic anemia. So why this becomes important is, clinically, if a patient comes and you are suspecting PSGN, but you send ANA, ANCA, you see that the patient has autoimmune hemolytic anemia, you send rheumatoid factor, all these can come positive in approximately 30% of patients. So this is one of the causes where ANA and ANCA are going to be false positive, but ANCA more so will be false positive in crescentic GN when PSGN is associated with crescents. Okay. So it is important to put the clinical and the laboratory investigations while making diagnosis for such patients. Now, what are the pathogenetic mechanisms by which this happens or IRGN happens? First is circulating immune complexes, like we discussed. Example, Streptococcus. This happens because there are circulating antibodies against SPEB and NAPLR. Then in situ immune complex formation. Again, Streptococcus is the example. Identification of the streptococcal pyrogenic exotoxin B in the subepithelial deposits in PSGN. Okay. Third is nephritogenic antigen deposition with complement activation. The organism is Streptococcus. This happens because of glomerular deposition of NAPLR with plasmin activity. That is, this is the third mechanism that we discussed, where the antigen goes and deposits in the kidney, or some molecular mimicry happens, and this mostly is seen in NAPLR. Okay. So here two important things you learned. One is, if it is in situ immune complex formation, the antigen causing it is SPEB. But if it's because of molecular mimicry, or if it's because of nephritogenic antigen deposition, then it is because of NAPLR. Okay. Now, for this, there is a super antigen which can bind to the antigen presenting cells. It activates T cells, it activates B cells, it can secrete cytokines. Okay. Again, this can happen in Streptococcus. The supportive evidence is there is selective peripheral blood activation of T cell receptors repertoire. Okay, so how this happens is, this goes and specifically binds to the T cell receptors. The antigen presenting cells are activated and T cell receptors are bound to. That's how this happens. Okay, so these are the pathogenetic mechanisms by which patients have post-streptococcal glomerulonephritis. Now, this is about bacteria. What happens in viruses? There can be direct renal cell infection, okay, especially in HIV and parvo, because virus got identified in the glomerular epithelial cells. There can be direct renal cell injury. First is infection, second is injury. This happens because of hepatitis B virus. Hepatitis B virus induces mesangial cell proliferation and production of collagen. So this further can lead to FSGS, mesangial proliferative glomerulonephritis, and it can further progress. Third mechanism of injury is cryoglobulin production, which is seen in hepatitis C. This is because in hepatitis C, you can identify cryoglobulins against the hepatitis C virus. So mostly it can be seen in type 2 and also in type 3 cryoglobulinemia. Okay. Now, epidemiology of PSGN, it is mostly seen in developing countries, that too in children. Okay. In developed countries, if it's happening, it is happening generally in immunosuppressed patients or adults with diabetes and malignancy or alcoholism. And post-streptococcal glomerulonephritis is the most common cause of acute nephritis in children, with male preponderance, with male is to female ratio being 2:1. And the age of occurrence, like I said, it's generally in children, which is between 2 to 14 years. Now, the risk of developing PSGN is 1 to 35%, okay, after streptococcal infection. So don't assume that everyone having streptococcal infections are going to have post-streptococcal glomerulonephritis. It's only 1 to 35%. And involvement of skin has 5 times more predilection to cause PSGN than involvement of throat. So this means impetigo, if a patient is getting impetigo, there is much further risk of causing PSGN than this patient developing upper respiratory tract infection. Okay, so impetigo causes impetigo caused by streptococcus strains are M47, 49, 55 and 57. See, generally these numbers are not asked, but even if they're asked in option, how you can remember is, you know that skin is a large organ, so the larger numbers go to the skin, like 47, 49, 55 and 57. Whereas respiratory tract is smaller when compared to skin. So you can remember the smaller numbers go to the respiratory tract. So respiratory tract infection caused by 1, 2, 4 and 12. Okay. Now when the person gets infection, antibiotics if given can reduce the risk of acquiring PSGN or the complications. Okay. And genetic predisposition occurs in HLA-DR4 and DR1. Okay. Now coming to the symptoms, like any other glomerulonephritis, there's going to be edema, there's going to be oliguria, there's going to be hypertension, elevated creatinine or reduced GFR, and urine features like hematuria. Okay, so edema is the most common feature seen in 80 to 90%. See, mostly it's a disease of children, so adults also can present with similar presentation. Okay, hypertension is seen in almost 80%. Then if you see, microscopic hematuria is seen in 100%. Okay, macroscopic hematuria is seen only in 30% of patients and oliguria 25 to 40. So children are going to come, all are going to have edema, all are going to have hypertension. You send urine routine, mostly they are going to have microscopic hematuria, and some can have reduced urine output and microscopic hematuria. Nephrotic syndrome is seen in 2%. Even AKI is very rare, it is seen in less than 1%. But in adults, however, majority will have AKI, somewhere around 30 to 40% will have AKI, and 20% of patients will have nephrotic syndrome. So the incidence of the complications occurring are more in adults when compared to children. Now, when you go to the investigation, the serum C3 levels, these are reduced in 90% by first 1 week, and it generally recovers by itself by 2 months. Okay, so you do C3 levels, it is reduced in 90% of patients. Okay, so this is the alternative pathway, and it recovers by 2 months. Then, like I told, cryoglobulins, anti-C1q antibodies, and rheumatoid factor can be positive in 1/3 of patients in the acute disease. Generally, in impetigo, PSGN occurs, the time period is 2 to 4 weeks, okay? But in pharyngeal infection or URTI, the PSGN occurs by 7 to 10 days. This is in contrast to IgA nephropathy, which is sympharingitic. Here, generally, there's a time lag. So, infection occurs, antibody has to form, then the antigen and antibody has to go deposit in the kidney. So, this time lag is what causes this lag for the glomerulonephritis presentation. And that too, it's more for impetigo, like how the nephrogenic stains were more in number, like that you can remember. So, it's 2 to 4 weeks in impetigo, whereas it's 7 to 10 days in pharyngeal infection. Okay. Now, other infections, other testing you can do is to prove what happens to the what has infected the patient. Okay, so if you do ASO titer, that is anti-streptococcal titers, more than 65% of patients will have this after throat infection. If you want for impetigo, then you have to do anti-DNase B. Okay, so this has been asked as question since our MD NEET time, right? So ASO titer is more for throat infection, whereas anti-DNase B is more for impetigo cases. Okay, and there is a panel called streptozyme panel, which will check 4 important antibodies, which is anti-DNase B, anti-hyaluronidase, ASO, and anti-streptokinase. These are present in more than 80% of patients. So you don't know what is causing the infection. There is no evidence. Then you send the streptozyme panel, which has ASO, anti-DNase B, along with the 2 other streptococcal antibodies, that is anti-hyaluronidase and anti-streptokinase antibodies. And this will be seen in more than 80% of patients. Okay. Now, once the child comes to you, you have to know that renal biopsy is not indicated in all, because if you give supportive therapy, then this is a self-limiting disease. Then in whom renal biopsy is indicated? Like in any other condition, if there are atypical features, then renal biopsy will be indicated. So what are the atypical features? Child having nephrotic range proteinuria. Like we discussed, the incidence of nephrotic syndrome is only less than 2%. So if it is occurring, then this child will require biopsy, because it can be some other. Decreased C3 levels more than a month. So generally I told that for 2 weeks it will be decreased, and by a month it is going to recover. So if it doesn't recover by a month, then we have to consider renal biopsy. Next is increasing renal dysfunction in 2 weeks. Okay. So think the child comes and creatinine is normal, but creatinine goes on elevating. Then you have to do biopsy. Fourth is age. If the age is higher, for example, adults, then oliguria is present for more than a week. Like how complement starts recovering within a week's time, even oliguria should start recovering within a week's time if it doesn't happen. And no clear history of preceding infection, that is, you are not able to localize a impetigo or a respiratory tract infection. So based on, let us divide this chart into based on history, physical examination, investigations. Okay, history, if there is no infection history that you are getting from the patient, or if the age is adult age, if the child is having oliguria more than a week. Okay, so these are the features on history that will help us show that this is an atypical case and it might require biopsy. Second is labs. In labs, if there is increased serum creatinine for more than 2 weeks, okay, and decreased C3 levels for more than 4 weeks, and there is nephrotic range proteinuria. Okay, so you understood the laboratory and the clinical parameters that will help you in deciding whether renal biopsy is required in a child with PSGN. Now, when you go to renal biopsy, you see light microscopy, immunofluorescence, and electron microscopy. So, in light microscopy, like you can see in this picture, there's going to be diffuse proliferation. Okay, so there is going to be diffuse proliferative glomerulonephritis, and there is going to be mesangial hypercellularity. So, you know that every glomeruli is made up of multiple endothelium. Then you know GBM is covering like this, and in between whatever is there is the mesangium. Okay, so there can be glomerular hypercellularity. So imagine multiple cells here. There can be mesangial hypercellularity also, and outside GBM is the podocyte, right? So here also if there is proliferation, then it is going to be crescents. So everywhere there is going to be so much inflammation that there is going to be proliferation. So there can be endothelial vessel, or it can be in the mesangium, it can be outside crescents. Okay, rare is MPGN or extensive crescents. Crescents are generally small and it is seen in only 50% of patients. So immunofluorescence, what is going to be there? There is going to be C3 and immunoglobulin, right? So dominant C3 staining you are going to see wherever antibodies are deposited, and immunoglobulin G and IgM is less frequent. Now you know what you are going to see. What you are not going to see is IgA and C1q. So that is very important. Okay, IgA you see in one specific type of IRG, and I'll come to that. But in PSGN you are going to see only C3 and immunoglobulin G. So this antibodies are arranged in certain pattern. So this has been asked as question previously. First pattern is called starry sky pattern. So what happens is, like we discussed, there's going to be capillary wall, there is going to be GBM, and there's going to be mesangium, right? So if the immunoglobulins are located in the capillary wall and in the mesangium, so imagine if this is dark, you're only going to see stars, right? You're going to see these things as stars. So it's called starry sky pattern. So immune deposits found in the capillary wall and in the mesangium. Next is Garland. It's not protein, sorry, Garland pattern. So what is Garland pattern is, here we know is the GBM and here you know is the epithelium, right? So here antibodies are going to be deposited. This, see, in real there's not going to be this much space. Okay, again and again I'm telling, because this I'm explaining so that you get the idea of that glomerular basement membrane and all these things. Okay, so there's going to be subepithelial humps, and once this subepithelial humps are deposited, you see how the deposition is. It's like a garland, right? So this is called as Garland pattern. So subepithelial humps that are deposits are called as Garland pattern. So last to disappear are mesangial C3 deposits, and not seen are Ig and C1q. So the starry sky pattern are nothing but what is seen in the glomerular capillary wall and in the mesangium. But Garland pattern is nothing but the subepithelial depositions of antigen and antibody. Okay. Now electron microscopy, again you're going to see subepithelial hump deposits which are typical of PSGN, and it is seen because of streptococcal pyrogenic exotoxin B. And capillary basement membrane reflects over the mesangium. So this area, wherever the capillary basement membrane reflects over the mesangium, this area you are going to see more antibodies. More antibodies. Okay, so this is what you're going to see in electron microscopy. So far in renal biopsy, we found that immunofluorescence is very important. Okay. Now, differential diagnosis C3GN, because I told plenty C3 deposits are going to be there in the kidney, so it becomes C3GN. PSGN is a self-limiting disease. Okay. And here what happens is C3 is dominant. In investigation, here C3 is dominant, here C3 need not be dominant in PSGN. Okay, so that's how you differentiate, and PSGN generally recovers. these do not recover and will have C3 deposition in the kidney for a long time. Other one is ANCA vasculitis, which can be a close differential because these patients can have crescents and also they are going to have ANCA antibodies positive presenting as glomerulonephritis. But ANCA vasculitis is mostly pauci-immune, that is, you're not going to find immune deposits in the kidney. Okay. Now this picture showing this is the light microscopy showing proliferation. There's endothelial proliferation and mesangial proliferation. This is the starry sky pattern that is seen in the mesangium and in the capillary wall. And this you can see is the garland pattern. This is the subepithelial humps that are deposited in the subepithelial space leading to garland pattern of immunofluorescence. Okay. Now what happens to these patients? In 1 month, they generally undergo resolution of clinical symptoms and ESRD is seen in less than 1% of patients. Okay. And some patients might have mild proteinuria and microscopic hematuria for 1 year. This is important because the child you think comes to you. By 1 month, the child is fully recovered. The complement becomes normal. Renal functions are normal. And you send them home. Then on follow-up, you notice that there is some trace proteinuria. There is some 5 to 6 RBCs. There is no need to panic. It is common and it can last up till 1 year. Okay. Only children who have nephrotic presentation, that is less than 2% of patients, will have poor prognosis. Now coming to management, if the infection is persistent, definitely treat the infection and give supportive treatment in acute nephritis. And this definitely has better prognosis than crescents of other condition, like it may be anti-GBM disease or vasculitis or SLE or IgA vasculitis, whatever is the reason, the crescents because of PSGN have better prognosis. Okay. Now coming to IgA dominant IRGN, we just finished with PSGN. Now coming to IgA dominant IRGN. So in PSGN, we saw that they will not have any IgA or C1q. In IgA dominant IRGN, they are going to have only IgA. Okay. So it is mostly seen in patients who have staphylococcus infections. So this IgA dominant IRGN is mostly seen in patients who are infected with Staphylococcus aureus. And it is seen in adults with underlying comorbidities like diabetes or malignancy. So what happens is these staphylococcal enterotoxins, they act as super antigens. That is, they are going to stimulate or activate everything. They bind to the antigen presenting cell. They activate the T cells. They release the cytokines and initiate polyclonal antibody response. Okay, so they go and activate APCs, not the specific cells anywhere. Once APC are activated, they go stimulate the T cells and then the cytokines are activated. This is going to activate B cells to produce antibody against Staphylococcus cell envelope antigen. This antigen co-localizes, this antigen gets deposited in the mesangium and co-localizes with IgA, glomerular IgA deposits. Okay, so this is what happens or the pathogenesis in IgA dominant IRGN. So in these patients, unlike in post-streptococcal glomerulonephritis, you can generally see an ongoing infection. That is, the patient might be having cellulitis of leg or wound of the leg or abscess of leg and they are going to come. Okay, it is generally seen in more than 65 years, seen in males more than females and generally in patients who have more comorbidities. Mostly it is MRSA only, like we are saying in any other infection. And it is more common in skin or visceral infection. So the clinical features in these patients are going to be rapid deterioration of renal function. Okay, so it's a very aggressive thing. And nephrotic syndrome is seen in 50% of patients. They are going to universally have microhematuria and gross hematuria is seen in 25%. So 50% will have nephrotic syndrome with rapid decline in renal function. So you can generally see these patients are diabetics with cellulitis suddenly becoming dialysis dependent. Okay, and low C3 is seen in 50 to 70% of patients. That is significant amount. So when you see light microscopy, again you see endocapillary or exudative glomerulonephritis. That is, in the capillaries there are going to be deposits of endocapillary hyperproliferation and there's going to be deposits of neutrophils, right? So this is nothing but endocapillary or exudative GN. More than mesangial proliferation. Again, mesangium can be proliferated or crescents can be there. Okay. In immunofluorescence, it's going to be C3 codominant with IgA. In PSGN, we saw it was IgG. So here we see that it is C3 codominant with IgA. In electron microscopy, there is going to be subepithelial and mesangial deposits of immunoglobulins, okay, like in other diseases. Now, how to differentiate this from IgA nephropathy, which will also have IgA deposits in the mesangium, okay. So, this is something we discussed in the chapter of IgA nephropathy also. In these patients, there are going to be coexistent staph infection. There's going to be severe proteinuria, that is 50% are going to have nephrotic syndrome, okay. And these patients are going to have low complement levels. Unlike in IgA nephropathy, they're going to have dominant C3 deposits along with IgA, but whereas in IgA, it's going to be more of IgA deposits than C3 deposits, okay. Kappa is going to be more than lambda and subepithelial humps. So basically, the thing of immune deposits, that is, patient having C3 more than IgA, subepithelial hump, and in the blood, you're going to see low complements. In patients having coexistent staphylococcal infection with severe proteinuria. So this is how you're going to differentiate this from IgA nephropathy. And there is worse prognosis when compared to IgA nephropathy. The prognosis of IgA dominant staphylococcal infection is worse when compared to IgA nephropathy. Okay. Now, treatment is infection with treat the infection, whatever coexistent infection with antibiotic. Corticosteroid treatment is contraindicated because it's going to worsen the infection and hence worsen the infection-related glomerulonephritis. Sometimes the infection can be life-threatening also. Now, endocarditis, we finished the second section, which is IgA dominant glomerulonephritis. Next, coming to endocarditis associated glomerulonephritis. This can be either acute or subacute. These are because immune complex with bacterial antigen gets deposited in the glomeruli, okay? And there is also formation of type 3 cryoglobulins. This is important. We know there are three types, right? Type 1, type 2 and type 3. Type 1 is monoclonal. Type 2 is monoclonal plus polyclonal. Type 3 is polyclonal. So type 3 cryoglobulinemia is seen in infective endocarditis. Now, this is mostly seen in epidemiology in at-risk patients. So, at-risk patients becomes diabetes or anyone with a prosthetic valve or anyone with a history of IV drug abuse, anyone with history of malignancy, malnutrition, alcohol. So, all these becomes at-risk patients. So, hospital-acquired infective endocarditis, it can be because of Staphylococcus aureus and epidermidis. And native valve endocarditis, it can be because of Streptococcus, okay. And next is culture negative endocarditis also can cause this glomerulonephritis, and gram negative organisms causing glomerulonephritis are rare. Now, coming to the clinical features. What clinical features are going to be there? Like in any other glomerulonephritis, there's going to be reduced glomerular filtration rate and RPRF. There's going to be microhematuria, mild proteinuria. For example, think cardiology sends a consult that infective endocarditis patient is there. Suddenly patient is having reduced urine output, elevated creatinine. You ask for urine routine, protein is going to be 1+ with some few RBCs. Okay. Some patients can also present with nephrotic syndrome. Then you have to suspect endocarditis. You have to send complement levels. Then once you get low C3, you can send complement levels and cryoglobulin levels. So when you get low C3 and type 3 cryoglobulins, then it can help you in making the diagnosis of infective endocarditis associated IRGN, okay. And there can also be elevated rheumatoid factor like we saw in the other condition. Now, in the biopsy, most common is crescentic GN, okay. So we saw that PSGN crescents are rare. IV associated also crescents can be there. But in infective endocarditis associated, crescents are most common, okay. There can be membranoproliferative glomerulonephritis, diffuse or focal endocapillary GN, okay. So these are the other presentations. Just remember, crescents are most common. So there the deposits are going to be C3 with IgG or IgA. And there are going to be electron dense deposits mostly in the mesangial area, followed by subepithelial and subendothelial. So mostly here the deposits are going to be in the mesangial area, okay. Now, coming to the next, that is shunt nephritis. Shunt nephritis is again an immune complex glomerulonephritis. It is mostly seen in infected ventriculoatrial shunts and ventriculoperitoneal shunt causing this is rare. Okay, so ventriculoatrial shunt is more common. Ventriculoperitoneal shunt causing this is rare. And 0.72% of shunt infection can cause GN. It's not that all patients who are getting shunt infections are going to develop this glomerulonephritis, only 0.7 to 2%. Okay, and most common cause causing this is Staphylococcus aureus and epidermidis, like in any other cutaneous infections. Okay, now coming to the clinical features, generally it can happen within 6 months of the surgery. Patient presenting with low-grade fever, rash, arthralgias, hepatosplenomegaly, hypertension and raised intracranial tension. So this will happen because it's like an immune phenomenon, right? So immune phenomenon causing glomerulonephritis can present as all these. Now there can be microscopic hematuria and also nephrotic range proteinuria in these patients. Diagnosis is by low C3, positive rheumatoid factor, positive ANCA, cryoglobulinemia. CSF will show increased eosinophils. And when you do biopsy, renal biopsy, mostly it is MPGN pattern in the biopsy. Okay, and immunofluorescence will show the same C3, IgG and IgM. And electron dense deposits can be subendothelial and mesangial. Now treatment is generally you start antibiotic therapy and you change the shunt VA to VP shunt, and if the patient requires dialysis you consider HD and not peritoneal dialysis, and complete recovery is seen in around 50% of patients. So some people are going to be left with residual elevated creatinine, and ESRD is seen in 6% of patients. Now GN with other bacterial infection. Here you should notice that abscesses will have normal complement. So this is one infection. Generally we know infection there is reduced C3. But here you see normal complements, probably because abscesses contain, it's not going to cause that much immune response stimulation and complement deposition. So you are going to find normal complement. Okay, this has been asked as a question. Now here abscess you have to treat till the infection settles. Okay, so treat the infection and that will settle the glomerulonephritis. Congenital syphilis, this is important. This presents as nephrotic syndrome in 4 to 12 months after birth. This has been asked. So renal involvement is in acquired syphilis, renal involvement is rare. Even if it occurs, membranous nephropathy occurs. And after treatment, remission occurs in 4 to 18 months. So in syphilis, what happens is congenital syphilis, 4 to 12 months after birth generally seen, and nephrotic syndrome is most common. Salmonella generally causes mesangial-proliferative glomerulonephritis. See, just remember any infection can cause mesangial proliferation. Okay. Leprosy, again immune complex mediated GN, and rare are amyloidosis with erythema nodosum. Again, Streptococcus pneumoniae can cause TMA. This we know because of the antibody, it can cause TMA. Because of the anti-neuraminidase antibody, it can cause TMA. Now, what does KDIGO glomerulonephritis guidelines 2021 tell about bacteria-associated glomerulonephritis? So, 4 important things are considered: post-infectious, shunt, endocarditis and IgA related, right? So, risk and clinical features in post-infectious is, it's mostly seen in the children and the elderly, immunocompromised host and with subsanitary living conditions, right? Shunt nephritis, it is highest in ventriculoatrial, mild in ventriculojugular and least in ventriculoperitoneal. So this is what we learned. In endocarditis related GN, it is seen in prosthetic valve or structural heart valve lesion, and if there is substance abuse or in immunosuppressed like elderly, diabetes, hepatitis C, HIV. Okay. In IgA dominant infection related GN, mostly because of diabetes, patients will have diabetes, elderly patients with heart disease, malignancy, alcohol abuse or kidney transplant. So these are the risk factors. So mostly it is seen in immunosuppressed individuals. Okay. Now here again this is PSGN. This is shunt associated glomerulonephritis. This is infective endocarditis associated glomerulonephritis. This is IgA dominant PSGN. Okay. Now history. In PSGN, seek evidence of antecedent resolved pharyngitis. Okay. 1 to 2 weeks for pharyngitis, 4 to 6 weeks in impetigo. In Fihali, it's mentioned as 2 to 4 weeks. In here, it is mentioned as 4 to 6 weeks. So, generally, you just remember the longer time, okay? 2 to 6 weeks, you can remember. In shunt nephritis, histories, they may present within months, like I told you, 6 months or decades of shunt placement, and sometimes even after shunt revision. Okay. The diagnosis may be confounded and difficult in the 40% of patients with occult infection. They can have occult infection. In infective endocarditis, you're going to get echocardiographic evidence of valvular vegetation. And in IgEs, there's going to be demonstration of active blood or tissue infection in the presence of acute GN. So infection with staphylococcus you're going to demonstrate. Physical examination in PSGN, some active skin or tonsil lesions can be present. In shunt, it's going to be non-specific signs or symptoms like lethargy, fever, clinical signs of bacteremia. Like we discussed, there are going to be features like some joint pain, rashes, arthralgia. They're going to come with that. In infective endocarditis, they're going to be fever. When you examine, there can be new or changed cardiac murmur, splenomegaly, and the characteristic skin lesions like JNV lesions. In IgA dominant, there's going to be frequent hypertension, and examination will show you some infection. Again here, PSGN. This is going to be shunt. This is going to be infective endocarditis, and this is going to be IgA dominant PSGN. Okay. So, laboratory, you're going to ask for urine analysis, urinary PCR, and you're going to measure serum creatinine and EGFR. So, here in PSGN, you culture skin or tonsil if infected, or you measure the ASO, which is common if there is throat infection, or you measure anti-DNase B, which is common in impetigo, right? Next is shunt. Okay. So here in shunt nephritis, you see the organism and you culture it in blood. In the CSF, you see that in CSF also you can find it. CSF eosinophils can be there, or you send the shunt tip for culture. Okay. And in infective endocarditis, blood culture is positive in 90 to 98% of patients and negative in only 2 to 10%. In whom it's going to be negative? Candida, Coxiella, Borrelia, Bartonella, in all these conditions. So here you will have to use some serology to identify these cases. Okay. In IgA dominant PSGN, the cultures, blood or tissue are going to identify the bacterial infection, mostly Staphylococcus, which is mostly MRSA more than MSSA. Okay. Next, coming to the laboratory testing, you assess for, apart from these, you assess for complement C3, C4, rheumatoid factor, cryoglobulin, and factor B antibody levels if there are some TMA. And you have to rule out other causes of nephritis, like you have to rule out SLE, you have to rule out ANCA. Okay. An important thing to remember in IgA dominant PSGN is IgA levels may not be high, just like in IgA nephropathy. Now, prognosis. Again, this is PSGN. This is going to be shunt nephritis. This is going to be infective endocarditis associated GN. And this is going to be IgA dominant PSGN. So, here in PSGN, we know that prognosis is excellent in children. In elderly also, it is good. What indicates poor prognosis in children and elderly is proteinuria. And in shunt, generally the outcome is good. All it requires is to remove the shunt, replace it, treat the infection. In infective endocarditis, this immediate prognosis is good, okay, if the infection is promptly eradicated. In IgA dominant PSGN has the worst prognosis. Dialysis will be frequently required, recovery is guarded, and less than 20% of patients only return to their normal renal function, okay. So, only 20% come to the baseline, rest 80% don't come to baseline and have very poor prognosis. Now, coming to the treatment, again here, PSGN, right here, shunt nephritis. Then here is infective endocarditis associated GN and IgA dominant PSGN. So, first is supportive treatment and antibiotics. Next, in PSGN, the value of high dose steroids is not known. And in shunt nephritis, mostly the shunt will have to be replaced. And in infective endocarditis also, glucocorticoids and immunosuppression, the effect is unproven because it can lead to worsening of infection. And in IgA dominant PSGN, we have to weigh the risk and benefits of immunosuppression and give, for example, dialysis dependent, infection is under control, then we can try treating them. Okay. So basically, immunosuppression per se is not very well studied, or there is no good proof in IRGN. Okay. Now, courses follow the kidney function, complements, urine analysis, ACR, and proteinuria at appropriate levels, maybe at 3 to 6 months until complete remission and they return to baseline. So this is how the course. So this is about KDIGO guidelines and what they told about bacterial infection related glomerulonephritis. Next, coming to the viruses. First is hepatitis A. It can cause mesangial proliferation or membranoproliferation. IgA nephropathy has temporal correlation with hepatitis A and recovery occurs with recovery of infection. So this is generally not asked in exam till now, so you don't have to worry. The important one is hepatitis B associated glomerulonephritis. Okay, so it is an immune complex mediated glomerulonephritis. HBeAg is present, which is a small cationic antigen which goes and forms subepithelial deposits. Like this is what I described there also in PSGN. If this is the endothelium, this is the GBM, and if this is the epithelium, the small cationic antigen, because of they're attracted by the negative charge, they go and they sit in the subepithelium. Okay, so this is HBeAg. HBcAg and HBsAg are generally large, so they cannot cross and they are going to be in the subendothelial area. So that is going to be HBcAg, the core antigen, and HBsAg. Okay, these are known to cause direct viral injury also by direct viral injury and also in situ antigen deposition. Okay, so it is chronic. HBV infection is chronic, more common in infants and than in adults. Chronic HBV infection. Okay. 3 to 5% of patients with chronic infection develops renal disease. And the most common glomerular disease in chronic HBV carriers is membranous nephropathy. Very, very important to remember. So it is mostly, we know chronicity is mostly seen in children. So it is seen between 6 to 12 years of age with males having more than females. But the wonder of these is this is generally going to be asymptomatic. Some patients can have nephrotic syndrome also. So it forms a spectrum. Okay, so generally it's going to be asymptomatic. And there's going to be normal renal function in these patients and generally liver disease also. HBsAg associated liver disease also is going to be minimal. Okay, so liver disease is going to be minimal. The renal function is going to be normal. Okay, so this is the thing, this is the peculiarity that they can be asymptomatic also. So it's a very mild disease. Now, spontaneous remission is common in these diseases. In adults, if this membranous nephropathy is happening, they can have proteinuria with reduced GFR, which is commonly not seen in children. In adults, 30% of them can go into CKD and 10% can go into ESRD. Hypocomplementemia will be seen, unlike in other membranous nephropathy, and it is seen in less than 50% of patients. Okay, and when you do electron microscopy, you are going to see mesangial or subendothelial deposits. With in immunofluorescence, you are going to see IgG4 type of immunoglobulin, and even PLA2 receptor can be positive. You know that PLA2 receptor that is seen in membranous nephropathy primary, it can also be seen in hepatitis B. It's going to be seen in hepatitis B and hepatitis C. Okay, so these are the conditions in which you can see PLA2 receptors. So clinically, it is this membranous nephropathy is most common glomerular disease that is seen in children or adults with chronic HBV infection. In children, it's generally asymptomatic and liver disease is going to be less and it's going to be resolving by itself. Whereas in adults, it can present with some proteinuria, it can present with some reduced GFR, it can progress to CKD, ESRD also. Okay. Now, the other lesion. So we learned that MN is the most common lesion, right? The second lesion that can occur is MPGN, which is second most common. It is seen in adults. Again, here complements are going to be reduced, both C3 and C4. So it can cause type 1 and type 3, and also if it's causing cryoglobulinemia, type 3. Among MPGN, type 1 and type 3, cryoglobulinemia type 3. Now, other HBV related renal involvement other than membranous nephropathy and MPGN, it can cause IgA nephropathy once the cirrhosis happens, or AA amyloidosis because of the chronicity. The most important is polyarteritis nodosa. This is not a glomerular disease per se, it is a vasculitis. I'll be dealing with this in detail in the chapter for vasculitis. Okay. Now, treatment is you have to treat with antivirals, which is lamivudine, entecavir, tenofovir. In children, they generally undergo spontaneous remission by 4 years with no treatment. Okay, and in children, if the kidney disease is progressing or spontaneous remission is not occurring, then we can consider steroid plus flex with antiviral agents. In adults, CKD can be seen in 30% of patients. Okay, now KDIGO guideline states that if there is a replicative HBV infection that is denoted by more than 2000 copies per ml and glomerulonephritis, they have to receive treatment with nucleotide analog, that is the same lamivudine, entecavir, tenofovir, that is prescribed for general population. Now next is going to be hepatitis C associated glomerular lesion. Okay, 90% of infected patients have chronic infection here, unlike in hepatitis B, and HCV induces a polyclonal immune response. That's why you see the cryoglobulin 2 and 3. Okay, HCV enveloped 2 antigen induces IgM rheumatoid factor response and cause cryoglobulinemia. So we know that. So it causes type 2 cryoglobulinemia and type 3 cryoglobulinemia. Okay. Now, presentation, it can present as asymptomatic, nephrotic. Complements are reduced, C3 and C4. And this is unlike in bacterial infections where only C3 was reduced. Okay. And they can present as MPGN, MN or cryoglobulinemia commonly. Now, most frequent of this is MPGN and majority have cryoglobulins. Like in HBV related, how we saw most frequent was MN, right? So here the most frequent is going to be MPGN. Okay, so basically wherever it goes and deposits and what inflammation it causes are important, and how each infection the response differs is based on where the antigen is located or where the antigen is going to create a response. Now, HCV associated membranous nephropathy generally will have HCV RNA positive. Cryoglobulinemia or rheumatoid factor are going to be absent and hypocomplementemia is going to be absent. So in this membranous nephropathy, unlike in membranous nephropathy with HBV where 50% had hypocomplementemia, type 3 cryoglobulins were seen. Okay. Now other lesions apart from MPGN, which is most common, and MN, there can be polyarteritis nodosa like in hepatitis B. But other important thing that it can cause is fibrillary GN and immunotactoid. See, all these are because of excessive deposition of antibodies, right? So this fibrillary and immunotactoid can happen. Even FSGS and mesangial-proliferative glomerulonephritis can happen. Now treatment is 15% of these patients reach ESRD. However, if we treat the cause, it can be lesser. Now directly antivirals are available and the treatment for 3 months will help in sustained virological remission in approximately 95 to 98% of patients. And treatment and curing the disease diminishes the risk of ESRD. So this is the KDIGO guidelines. So if you have a patient with HCV and glomerulonephritis like RPGN or nephrotic syndrome who are undergoing DA treatment already, then you consider biopsy and immunosuppression. But if they are not undergoing treatment, that is no treatment, then you see if there is distinguishing feature of typical presentation like there is hematuria, reduced complements, cryoglobulins, systemic signs of cryoglobulinemia like rashes, purpura, rheumatoid factor positivity. Okay, so you see if the number of factors which are checked above are positive. If it is 0, it is typical presentation. So you see first if patient is already having HCV and taking treatment for DA. Okay, if they're taking treatment, then patient is improving, don't do anything. If patient is not improving, then you have to consider biopsy and immunosuppression. Now you see distinguishing features that can help you in suggesting HCV associated glomerulonephritis like hematuria, reduced C4 levels, cryoglobulins, both in the blood and systemic feature, rheumatoid factor. So if there are typical features, then you see call it as typical presentation. If EGFR is stable and proteinuria status is stable, then you don't consider biopsy. But if it is atypical features or EGFR or proteinuria continues to deteriorate despite SVR, then you consider biopsy and immunosuppression. So if the patient is stable on treatment and if there is no deterioration of GFR or no worsening of proteinuria, we can wait and watch. Okay. Now that is what HCV infection with typical features, wait and watch. Stable kidney function, no nephrotic syndrome, no biopsy, just DA. RPGN or cryoglobulinemia, we have to give directly antivirals with immunosuppression with or without plasma exchange. Okay, rituximab is generally first line in these patients for immunosuppression in hepatitis C. If there is nephrotic syndrome with complication, also immunosuppression. If there is no response to DA, also rituximab. So immunosuppression that is considered important here is rituximab. Okay. So basically, if they're stable, don't do anything. Just give directly acting antiviral. If they're unstable, as in they are going to have any nephrotic syndrome or RPGN, then biopsy and consider immunosuppression. The immunosuppressant of choice is rituximab. Okay. Now coming to malaria. Malaria generally falciparum and Plasmodium malaria can cause GNs in human. It is because of the antigen-antibody complex deposition or in situ immune complex formation, which leads to direct activation of the complement pathway. Okay, so here you can see malaria goes and binds to the erythrocyte. Erythrocyte parasitism is seen. It can cause immune response like in glomerulonephritis, cytoadherence leading to tissue hypoperfusion, leading to reduced renal perfusion, ATN, and acute kidney injury. In cytokine or inflammatory mediator release, it can cause hypovolemia, hemolysis, rhabdomyolysis, hyperviscosity, jaundice or hyperbilirubinemia, DIC. So this is the systemic feature. Okay, so this is multiple mechanisms by which it can cause kidney injury by glomerulonephritis, by ATN, AKI. Okay. Now clinical features are Plasmodium falciparum. You mostly see a mesangic proliferative glomerulonephritis. So there is going to be microhematuria, some proteinuria. Okay. They can also cause AKI. Plasmodium malariae is what is important. In 4 to 8 years of age, it can cause SRNS, which is called as tropical nephrotic syndrome. So tropical nephrotic syndrome is nothing but SRNS. It is seen because of infection, because of Plasmodium malariae. Okay. In adults, it can cause GN and hypertension. Mostly it is MPGN, and despite treatment, it progresses to ESRD. So this is generally resistant to all treatments and it is going to progress to ESRD. Plasmodium vivax can cause AKI and TMA. So this is the histological staging of cotton malarial nephropathy, how it develops the steroid-resistant nephrotic syndrome. Initially, there's going to be mild focal and segmental disease. Then it's going to progress to moderate disease. Then there's going to be diffuse lesions with interstitial and tubular changes. And there's going to be marked sclerosis and IFTA. Okay. So this is what is seen. Treatment is to eradicate malaria and no indication of immunosuppression. So this is just for completion. Wuchereria bancrofti we know causes chyluria. It can cause mesangioproliferative glomerulonephritis. And there can be worsening of proteinuria and hematuria with treatment, okay, because the immune response is going to increase. Next is Oncosarca, which is MPGN, SRNS, and again worsening of proteinuria and hematuria can occur with treatment. Same like this parasite, okay. Then lower eradication of parasite is not sufficient in resolving GN like in other infections. So see, I have just put the salient points which can get picked up as MCQs, but I don't think these will be asked. Okay, leishmaniasis again can cause mesangioproliferation and MPGN. Now, coming to quick revision after this laborious session, coming back to a quick revision. So, antigen responsible for subepithelial hump in PSGN is SPEB, streptococcal pyrogenic exotoxin B. So, we discussed that this is a cationic antigen and it is going to go and cause this. Okay, autoantibodies in PSGN, this we know that they can be positive for cryoglobulins, they can be positive for rheumatoid factor, they can be having ANA, they can be having ANCA, and they can also have antibodies for autoimmune hemolytic anemia. So impetigo versus PSGN in pharyngitis. So we know impetigo is more chance to cause PSGN than pharyngitis. And these are the bigger strains, bigger number strains like 43, 47 and 50. Here it is a smaller number of strains. Okay, the number as in the numerical will be smaller. Then impetigo generally takes 2 to 4 weeks to cause PSGN. Here it is 7 to 10 days. Okay, and in throat infection generally or pharyngitis we have to check mostly for ASO titer, and in impetigo we have to check for anti-DNase B titer. Okay. Now, atypical features indicating need for biopsy in PSGN. This can be children who are presenting with nephrotic syndrome or oliguria that is persisting for more than 1 week. Okay. And clinically, they are going to have low complements for more than 4 weeks, and they're going to have deranged RFT or any adults. Okay. Now, IF patterns in PSGN. There can be two patterns. One is starry sky. This I discussed is mesangial and capillary wall deposition of antibodies. Other one is garland, which is nothing but subepithelial deposits of antibodies. Types of cryoglobulins in infective endocarditis, it is mostly type 3 antibodies that you're going to see in infective endocarditis. Complement levels in abscess are going to be normal. Most common glomerular lesion in HBV and HCV, very important. In HBV, it is going to be membranous nephropathy, and in HCV, it's going to be MPGN. So, membranous nephropathy in hepatitis B, generally, it is seen in patients with chronic infection, which is most common in children than in adults. So, in children, it can generally be asymptomatic. They can also present with nephrotic syndrome. Liver disease is going to be very less, and they're going to undergo spontaneous remission. So, this has been asked as MCQ multiple times. Again, when it occurs in adults, there can be hypocomplementemia, and there can be deranged GFR, and they can go into CKD, and 10% can go into ESRD, 30% can go into CKD. Okay. Tropical nephrotic syndrome, we know, is mostly seen in children. It is going to be seen in Plasmodium malariae, and it's a treatment-resistant nephrotic syndrome, and generally they are going to progress to ESRD. Thank you, friends. I hope I have helped you in understanding this topic. See you in the next class.